Hello everyone. I'd like to thank to being invited today for this to present on the work we've been doing. So today I would like to present some of the work we've been doing over the last couple of years, looking at economic evaluations and case finding amongst people who inject drugs for hepatitis C. So this is work that's been done at the University of Bristol and London School of Hygiene and Tropical Medicine, mainly by Zoe Ward and Jack Williams. So why do we undertake economic evaluations? Well, the main reason to do this is to inform decision making because resources are scarce. It's to compare interventions with alternatives to make decisions about which interventions to take forward. And there's also thresholds for cost effectiveness decided by NICE in the UK on what benefit we need to achieve with certain investment of resources for it to be worthwhile. So this is crucial for scaling up hepatitis C treatment in the UK. So in undertaking an economic analysis, I thought it'd be important to give a few details of the things that we do include in those analyses. Firstly, when we look at the incremental cost of an intervention, we take into account the costs of the testing and the treatment that's undertaken. So that's basically the intervention we're considering. However, we also take into account the healthcare costs of what could be averted through doing that testing and treatment. So if somebody would have been progressing to end-stage liver disease with associated healthcare costs, maybe we've averted some of that through treating them earlier in their stage of infection. We also incorporate the incremental benefits in terms of quality-adjusted life years saved, and people don't really generally understand what these are, so I thought I'd maybe give a little bit of information about what they are. So these incorporate the life years saved from your intervention, but also it gives a measure of how well you were in those life years saved. So one QALY is 1 year of perfect health. So if you were saved a year of health but you weren't feeling great, then it would be less than 1 QALY for that year of survival. And importantly, for hepatitis C, in our models, we try and incorporate the health benefits to the patients that are given the treatment, but also the health benefits to those people that might not have got infected due to you treating this infection, which may have caused onward infections in the past. We also incorporate discounting. Now, discounting is something that NICE wants us to do. We discount costs and we discount health benefits. And the whole reason we do this is we value things now more than we value things in the future. So if you want health benefits, you want those benefits, you prefer them now than 30 years in the future when we don't really know what's going to happen. And so we value that less. And then for NICE, NICE considers anything to be cost effective if it costs less than £20,000 per QALY saved. So that's £20,000 per 1 year of perfect health. So in terms of economic analysis of case finding, there has been previous work on this, and a lot of this fed into the NICE guidance for hepatitis C case finding in 2012. And in that guidance, there was a number of interventions that were considered. There was looking at case finding of ex-injectors in a GP setting. There was dry blood spot testing in drug treatment services, and there was opt-out testing in prisons. However, all of these analyses considered the old treatments, the interferon-based treatments. Now, recently there's been a lot of new case-finding strategies being piloted, and this has been linked to the scaling up of the new highly efficacious treatments. And the main aims of our work was to evaluate some of these interventions, and then importantly, I think the next step to look at is which ones of these should be scaled up to increase treatment uptake. So these are the interventions that I'll be talking about today. So firstly, HepCATT. HepCATT is an intervention that occurred in 3 different cities in the UK. It involved putting a nurse into a drug treatment centre. And the role of the nurse was to increase testing. It was to reconnect people that had already been diagnosed but had been lost to follow-up, weren't in a treatment pathway, to re-engage them. And then they were also there to improve treatment referral to secondary care. So the treatment wasn't occurring in a drug treatment centre in this one. The referral was also aided by peers and key workers. And the study found that doing this intervention increased testing 2.5-fold in the drug treatment centres where it was where the intervention occurred. It also increased engagement tenfold, so 10 times more people were engaged into treatment. And when we undertook the cost effectiveness of this analysis, it suggested that it would cost £9,000 per QALY at the full list price of the drugs. Now, this is an important thing. Nobody really knows how much the drugs cost. The full list price is £39,000 per one treatment course. Nobody really believes that's actually how much the NHS is paying, but we officially don't really know how much they are paying. Anyway, importantly, if you reduce that drug cost, if you assume it's £4,000 per drug treatment, then that intervention is actually cost saving. So what that means is you're saving money and you're getting added health benefits. So it's, in a way, a no-brainer. You should do it. We also did some modelling where we looked at how much impact this intervention could have if you scaled it up. So if you went to all drug treatment services and you put a nurse in each one, you don't need to put one in each one because in this intervention they rotated a number of different clinics. Then you could actually reduce incidence in people who inject drugs by 50% by 2030, showing how important this intervention could be for achieving the elimination target. The second intervention we looked at is Eradicate. So Eradicate is a needle exchange based intervention. So this was done in Dundee in 2014 to 2016, and they put a nurse into the needle exchange. And this was just considering active people who inject drugs. And the important thing here, this was actually still an interferon-based treatment they were using here, but they still were having no hospital appointments, and they were doing the treatment actually in the needle exchange. And they had incentives for visits to try and keep them coming. But those incentives weren't great. It was giving them things like a protein drink and things like that. It wasn't big things. And some shopping tokens. And what this intervention found, it managed to treat 94 people during the period of the intervention. It achieved an 80% SVR, which is quite impressive for interferon-based treatments. Interestingly, though, they did have a high reinfection rate, which some people might see as being a bad thing, and a reinfection rate of 20 per 100 person years. But it also showed that they were actually capturing the higher risk people who inject drugs, the ones that are actually still transmitting and acquiring infection. When we looked at this intervention, we actually found that this intervention was cost-saving at the full drug list price. And interestingly, if you reduce the drug list price, then it actually became cost-effective instead of cost-saving. And the reason this is a little bit unusual is because it was considering the interferon-based treatments, which are cheaper than the DAA treatments. So another one we've just been looking at and just submitted is HepCare London. So this is the find and treat intervention, which Alistair was talking about earlier when he stood up. So this intervention is a mobile outreach intervention which uses nurses and peer workers. It visits homeless hostels, drug treatment centres, and also street locations to identify rough sleepers. It uses an antibody point of care test using saliva sample to diagnose people as antibody positive, and then uses RNA, dry blood spot testing, and FibroScan if it's positive. The peer workers and the nurses then support treatment referral to secondary care if they're found to be diagnosed. So in this intervention, they've screened 462 people and diagnosed 200 RNA positive individuals and initiated 99 onto treatment so far. So quite a good cascade of care. The cost effectiveness of this intervention compares very similarly to the drug treatment centre intervention, is also £9,000 per QALY saved at the full drug list price. And this intervention also becomes cost saving as you reduce that drug treatment cost. The last one I'd like to consider is accident emergency screening. So this is the viremic project, which is undertaken in St Guy's and St Thomas's Hospital in London. So this is an initial scoping analysis looking at whether this intervention could be cost effective because it hasn't been completed yet. So there's been a number of sort of interventions that have looked at the proportion diagnosed in accident emergency and looked at whether they can be referred to treatment. So we considered analysis of what level of yield and what level of referral would make this intervention cost effective. And we found that if you had a prevalence over 0.7% antibody prevalence amongst those people in your accident and emergency, then pretty much at quite low levels of referral to treatment, that intervention would still be cost effective in the eyes of NICE. So in summary, I presented a number of different cost effectiveness analyses of a number of different case finding interventions. One I didn't present was prison opt-out testing, which also has a similar level of cost effectiveness and analysis that we did in 2016. And I think what these analyses show is that there are many cost-effective options for increasing screening amongst people who inject drugs. And many of these could be cost-saving as the drug costs decrease to levels that are likely to be already. All of these involve some sort of decentralisation, putting a nurse into a setting where a nurse wouldn't be to help the process, but also the use of peer workers or key workers to help the process along. The important thing to remember is all of these were compared to existing standard of care though. What is happening now is that standard of care is improving. So as we go forward, we have to compare these interventions with what is already scaling up. And that may affect the cost effectiveness of one intervention. Because if you've already got one, say, in needle exchange, or no, in drug services and you put one in needle exchange, maybe that intervention may be less cost effective because you're tackling most of those people in the other setting. So it's how you combine them now to get the most cost-effective scale-up of treatment, sufficient scale-up to meet the targets that we want to reach. And that's the next question of what I want to do. But unfortunately, that answer isn't answered yet. Thank you.